international guests, this Sunday, tomorrow, is in the general elections time. So when we designed with ATAXIA this conference, actually the government hasn't informed us, of course, of this general election, and that's why that was a very huge burden for us. So because we have done the commitment and we have made our commitment to our partners, that was very difficult to change dates. That's the reason why our main neurologists, the ones that we cooperate with, they are coming out of all places in Greece, speaking through Zoom. We will start in 1 minute. I see everyone is coming. And that's the reason that we have made these modifications. Please take your seats. Okay. We will start by introducing our first, for the Greek panel, let's say, speaker of the day, which actually is Professor Kimiskidis Vasilios. I salute everyone. I salute Professor Koutsis, who is, I see him online, Professor Zafiriou, Professor Karadima, and Professor Vasilios Kimiskidis. Professor Dinopoulos is here with us. Yorgos Zivgoulis, unfortunately, he had a bad headache, and he's not going to join us. So we will, without further ado, sorry for letting you, let's say, a little bit late out of the schedule. It has been a wonderful sessions till now, and this is the reason that the schedule has fallen a little bit behind. But without further ado, I will introduce Professor Vasilios Kimiskidis, who is a professor in neurology in HEPA University Hospital in Thessaloniki and Aristotle University. He is a very good friend of our association, and we are very happy and fortunate that we cooperate with him. Professor Kimiskidis, the floor is yours.
So, dear colleagues, ladies and gentlemen, first of all, please let me express my sincere thanks to the Hellenic Free Drugs ATAXIA Association and to Vasilis Karagias in particular for organizing this event and, of course, for the kind invitation to participate. These are my disclosures. So in the next very few minutes, I will outline the care of FA patients at my center, which is located at the HEPA Hospital of the Aristotle University of Thessaloniki. The care of these patients actually takes place at the NDA neuromuscular unit in the HEPA Hospital. And it reflects a collaboration between the Laboratory of Clinical Neurophysiology, which is led by Associate Professor Marian Thernotoglou, the second University Department of Pediatrics, which is represented by Professor Evangelos Pavlou, and the first Department of Neurology, which is directed by me. And I would like to stress the importance of the close collaboration between pediatricians and adult neurologists, because these close collaborations ensures the smooth transition of patients from the care of the former, the pediatricians, to the care of the latter, the adult neurologists. Currently, we follow and care for a cohort of 13 adult FA patients, aged 17 to 47 years, with a mean age of 29. And the essence of this care is crystallized in the word multidisciplinarity. All patients typically attend our unit on an annual basis, once per year, not including, of course, extra visits should any emergency, any special issue occur. And during each one of these visits, the patients are sequentially examined by a neurologist who is leading the overall care, as well as a cardiologist, an orthopedic surgeon, a pulmonologist, a physiotherapist, and a psychologist. In addition to that, consultations by all relevant specialties, for instance, ophthalmologists, ENT surgeons, clinical geneticists, or specialists in diabetes, are arranged as needed while the patient is on site. And in my humble opinion, this is a major advantage because mobility issues are of obvious importance to FA patients, and therefore the minimization of transfer time, of transfer cost, and transfer effort is considered highly beneficial by both patients and their caregivers. Now, just a few words about the contribution of each member of our team. The neurologist, as already said, is the overall coordinator. He or she assesses the patient urologically at each visit with clinical measures, standard measures such as SARA and FAS, and summarizes and assesses the results of all other examinations and assessments such as cardiac, biochemical, neurophysiological, or imaging. And thereby he can monitor both the primary and the secondary symptoms of the disease. So he is the coordinator. Our physiotherapist is involved in the design and the monitoring of the individualized rehabilitation plan. I will not enter in details, but certain key elements of this plan, which of course is designed based on the ambulatory status of the patient, as shown in the slide. One particularly important facet of the collaboration between the physiotherapist and the neurologist is the management of spasticity. As a first step, non-pharmacological measures such as strengthening and muscle stretching are introduced by the physiotherapist. But as a second step, pharmacological measures, both systematic drugs as well as local pharmacological measures, for instance, botulinum toxin, are used at our department. Our notable in particular has the expertise to utilize effectively this treatment in appropriate cases. The contribution of the cardiologist cannot be overemphasized. He is on site, I repeat, and performs ECG and echocardiography on each and every visit. And should concerns about cardiac arrhythmias emerge, he arranges everything. He arranges Holter monitoring or loop recordings or any other appropriate investigations and interventions. The pulmonologist is also on site and provides a comprehensive assessment of respiratory function, but also explores the presence of sleep disordered breathing and arranges appropriate testing and management. The orthopedic surgeon, again, is also on site. So all these people gather together when the patients arrive and routinely performs spinal examination, monitors care progression, and provides helpful suggestions about bracing, about scoliosis surgery, and about the management and investigation of osteoporosis. Last but not least, our psychologist screens for mental health issue or patients for the presence of depressions, for the presence of anxiety or psychosis. This is extremely important. She also provides a first level of management, but if needed, patients are readily transferred, readily referred to psychiatrists for further pharmacological treatment. I previously mentioned that consultations by other specialists are readily available at our unit. Let me give you just two examples. For instance, patients with swallowing difficulties. So for these patients, a comprehensive assessment by a relevant ENT expert is feasible, is available, and then on the basis of the results, he suggests strategies to overcome dysphagia. And similarly, a consultation by an ophthalmologist is regularly requested to assess vision and also rule other causes of vision deterioration in these patients, non-FA related causes, or of course, the presence of diabetic retinopathy. Finally, speaking of treatments, all of our patients receive symptomatic medications for the various aspects of the disease, as already mentioned. And just three of them, receive Q10 and vitamin E. Now, why three of them? These were ambulatory patients that had low levels of both Q10 and vitamin E. So we decided on the basis of some fairly low quality evidence, admittedly, to administer them. However, none of our patients received specific FA treatment. I refer to Skyclarys, of course, and it would be a major benefit for all patients in Greece if this would be feasible, for instance, via an early access program. And I believe that I echo the opinion of all our Greek colleagues on this issue. We are hopeful that the management scheme that I outlined covers the needs of our patients, at least to some degree. Of course, more can be done and more should be done to improve further the management of these patients. And ideally, it should be done through collaboration with the Hellenic Friedreich's Ataxia Association, and of course, with all other centers in Greece and abroad. And I would be happy to discuss any specific aspects on this issue. So I thank you for your attention.
Thank you, Professor. Thank you for this concise presentation of the capabilities that we have at HEPA University in Thessaloniki. And I welcome Professor Zafiriou Dimitrios, who is a pediatric neurologist, and he is the head of the Hippocrates University Hospital in Thessaloniki Pediatric Neurology Services. He will speak about also the capabilities that they have in their center and how they manage our patients in their center. Professor, the floor is yours.
Thank you very much, Mr. Karagias, for this wonderful opportunity to gather with other colleagues all among Europe. Unfortunately, in a difficult weekend for Greece, I mean, from an organizational point of view, I wish you know that I have managed first to be with you at Pieria, at Litochoro at this very moment, but unfortunately, some problems that arise through this election weekend made this impossible. But again, thank you very much for this very kind invitation to talk. I think on behalf of my other colleagues, pediatric neurologists in Greece, but mainly for Thessaloniki and from the scope of the child neurologist regarding the opportunities and the possibilities that we have to follow, diagnose first, follow, and why not provide more substantive therapy for patients with Friedreich's ataxia. I will not have any slides. I think that Vasilis Kimiskidis made a wonderful introduction because more or less this collaboration scheme that is followed in a HEPA hospital for adult patients with Friedreich's ataxia is more or less what we are doing in Hippocrates Hospital. But I would like to underline some special aspects of Friedreich's ataxia regarding the pediatric age. First, that most of these patients, they do have their first symptoms during the first 2 decades of life. So I think that first, it's the duty of a pediatric neurologist to diagnose Friedreich's ataxia. There are, of course, some patients that manifest symptoms after the second decade of life, but most of these patients, they do present in pediatric age, so we have this special knowledge of these symptoms, which are mainly neurological. We follow more than 10 patients, pediatric patients under 70 years, and I assume that at least 3 or 4 of the patients that are followed in a HEPA hospital are patients first diagnosed by us at Hippocratean Clinical Hospital at the first pediatric clinic. We have the same way to follow these patients. It's a multidisciplinary approach with the neurology or the neurologist organizing the follow-up, but also having other doctors. I would add here also the endocrinologist, the pediatric endocrinologist, because as you know better than myself, diabetes is a common manifestation of Friedreich ataxia, and we need also help in this issue. We have the whole range of physical therapists in Hippocratio. There's a special developmental center called Center Focus, where we have the occupational speech therapists and the physical therapists, and we are trying to stay in line with what our colleagues in special centers all over the world are doing regarding the scales that are used, the motor scales, I mean, but also swallowing scales and every other scale, trying to make us speak a common language when we refer to these patients. And this is very important. I'll come very quickly to what I think is the most important aspect of my presentation to you, because this way, having all these specialists and having all this knowledge as our colleagues abroad make us very capable of taking part into clinical trials. And this is something that I would like to underline. My center participates in more than 20 clinical trials, more than 8 having to do with neuromuscular disorders, spinal muscular atrophy, Duchenne, epilepsy, multiple sclerosis, and all other areas of pediatric neurology. And I think this is something that through the years give us knowledge about how we can proceed with these patients and having meticulously follow up, as Vasilis explained, to our little pediatric patients. So the same is true also for 1 or 2 centers in Athens, of course. My good friend and colleague, Argyris Dinopoulos, almost participate in every trial that we are as well. And we have our collaboration with our adult colleagues, and we are trying to make this transition possible. However, as you may well know, sometimes the pediatric patients are stuck into pediatricians or pediatric neurologists, and this is something that needs to be further worked on in order to ensure a smooth transition from pediatric to adult age. It's very important that in cases where new therapies, new innovative therapies, precision therapies arise, we can work together with our colleagues, adult neurologists. This was the case in at least 2 novel medications for therapies for spinal muscular atrophy. And I think that we are more than ready to have patients, both pediatric and adults, participate in any new clinical trial, but also to give them the opportunity to try at least the novel medication that has already got permission from the FDA regarding Friedreich ataxia. But apart also from Friedreich's ataxia, and because this is, as Vasilis Karadzias told me, Euro-ataxia project, of course, we all know that Friedreich ataxia is the most common ataxia, at least genetic ataxia, at least in childhood. But I think there is the knowledge of the people here and the possibility to work multidisciplinary to diagnose other forms of inherited ataxias. Also through the genetic, you know very well that we diagnose at least 70% more spinocerebellar ataxias or spinal hereditary spastic paraplegias, or some metabolic disorder, like, for example, peroxisomal disorders that may mimic some Friedreich ataxia. So I think that Greece is more than ready, and I speak for my town Thessaloniki, but I assume it's the same for Athens, to help these patients in a scientific way done in other parts of Europe and America as well. Regarding therapies, I think that mostly our patients, my patients, receive supportive therapy. 6 of the 10 patients receive idepedon. And we have seen some stabilization, but to be honest, we don't have a measure apart from typical cardiologist measurement regarding the wall of the thickness of the wall of the left ventricle to say that this works. But at least from a cardiologist point of view, our little patients are doing relatively well. I know that we don't have too many evidence of proof for idepedon, but many patients read some papers that, although contradictory, they maybe report a small benefit, so that's why we are given. I don't think there is a robust body of evidence for any other therapies like vitamin E or coenzyme Q, but you know better than me that where there's no therapy, every therapy, even with a very, very tiny positive effect, is better than no therapy. With these words, I say that we are ready to cooperate with our pediatric colleagues in other parts of Greece, that are adult neurologists, our colleagues, as we have done in the past, in order to give patients with Friedreich ataxia the best possible clinical care from a very high scientific point of view. Thank you very much.
Thank you, Professor. Thank you for showcasing exactly the capabilities that we have, and it is very important for our patients to understand that throughout Greece, even though it's a small country, it has been a substantive network of key experts and key expert centers for their treatment. And this is something that it is very well established over the years, and we are very happy that we cooperate with you. So I will move on to Professor Yorgos Koutsis, who actually is the professor in neurology and neurogenetics at the Genitio Hospital in Athens, which actually is the European reference network for rare neuromuscular diseases, and he is part of the EFACTS also study. So we heard earlier this day from Dr. Jörg Schulz about the EFACTS and the work that you have done. Professor Koutsis, thank you for being with us and showing what we are doing there in Genitio. Thank you.
Thank you very much, Mr. Karadzias. It's an honor for me to be speaking here. Were it not for the elections, I would be there with you. So I'm very glad you invited me. I will share screen because short talk for you while I hope now this is visible. Because as mentioned previously, this is an ATAXIA meeting and not just a Friedreich's ataxia. I will give you some data from Greece, some numbers regarding both Friedreich's ataxia and other repeat expansion ataxias that we've been studying for several years in Athens. I want to say that I have co-headed, along with Professor Georgia Karadima for the past 6 years now, the neurogenetics unit at the first department of neurology in the University of Athens, the Genitio Hospital. So I will talk a bit about who we are and give you some numbers concerning the patients we see, but Georgia will tell you a lot more about the laboratory side of things and what kind of tests we've done all these years. And then I will give you some data, the sort of thing we have collected over the years regarding Friedreich's and some other repeat expansion ataxias in Greece. So the neurogenetics unit in Athens is quite unique in Greek terms. It was founded in the early 90s by Professor Vasilopoulos, who in the area of neurogenetics has been a great leader in Greece and was a teacher of all of us. The vision is that it combines a very specialized outpatient neurogenetics clinic with a neurogenetics laboratory, and that brings patients and investigations together and helps us reach final molecular diagnosis in more patients, and then take it from there towards genetic counseling, follow-up, and treatment. The unit has been strengthened considerably by being part of the first department of neurology, which is part of the ERN R&D network, and therefore now participates in the ATAXIA and HSP disease groups of ERN R&D. But it's also been very important for us that we've been part of EFACTS for the last 5 years now. I think that should be also noted. From my point of view, I had the clinical side of things. So we've been running a neurogenetics clinic now for many years. Just to give you the data of the last 10 years, we have seen over 4,000 patients. And regarding ataxias, about 12 to 13% of our workload concerns ataxias. So we're not pure ataxia experts. I don't think in Greece one could say that there are neurologists that are so focused on ataxia, but a substantial amount of our work and our interest is devoted to ataxias. We examine these patients, we follow them up, we score them with SARA scores. If they are parts of EFACTS, they are studied in much more detail by my colleague, Dr. Konyari, who is, I think, the only person from our group that has actually is with you there and can talk to you more about this side of things. I just want to show you a map because the neurogenetics unit is quite unique in its characteristics. Within the Greek public sector, we have more or less diagnosed patients with Friedreich's ataxia since 1997, and I think most of our colleagues in Greece refer, at least for molecular diagnosis, their cases to the unit. So you can see an overview of all the patients that have been diagnosed in the unit in the last over 25 years. It's 117 patients in total, and you can see the geographical distribution. It shows that it's widespread. There are families with Friedreich's all over Greece, it's definitely, from our point of view, the most commonly diagnosed hereditary ataxia. We don't follow up, of course, all of these patients. A lot of these patients are followed up systematically in other centers like Thessaloniki, Professor Kimiskidis, by pediatric neurologists, Professor Dinopoulos, Professor Zafiriou, people in Patra like Professor Chroni. But we do often diagnose them and we have an overview. We follow quite a lot of patients in Athens because of EFACTS also, and we have entered 32 patients into EFACTS and follow them at least once a year. So we've looked into the genetic epidemiology of Friedreich's some years back. There might be some areas in the Aegean which have clusters of the disease, and some islands such as Ikaria or Milos we found had more cases than expected. But the overall prevalence, based on our data, is around 1 in 100,000 patients, which is a bit less than some Western European countries, but still significant. When we look at our cohort, we see that if we focus on early onset ataxia or recessive ataxia, so affected siblings, around 50% of our cases, and this is from a series of 192 index cases seen over 24 years, are Friedreich's ataxia. And of course, we have a picture of these patients at presentation, even though we only follow a minority of them regularly. You can see that in terms of sex ratio, they are equally divided. Their age at presentation is around 25 years, so there is diagnostic delay there. The age at onset in our cohort, the mean age at onset is around 15 years of age. And we have 15 patients, around 12%, which have a late onset and milder disease. You can see here data from our EFACTS cohort. 13 patients have been followed up for at least 3 years, and you can see the rate of change of the SARA score, just to make a point of how these patients are properly characterized within the EFACTS consortium. I have a few things to say regarding other repeat expansion ataxias, which we have been systematically diagnosing at least for the last 12 years. The SCARS, Fragile X tremor ataxia syndrome, and CANVAS, a more recent addition. And you can see in the map on the left, there is a distribution in the patients we've diagnosed, less so than in Friedreich's. I'm not so sure that we are receiving perhaps as many referrals as we could have for these ataxias. You can see that these are much rarer diseases. In total, all these patients are 37 diagnosed cases that come from 31 families. This is shown here in a bit more detail. Greece primarily has SCAR1, SCAR2, and SCAR7 regarding the classic SCARs. SCAR3, Machado-Joseph's disease, and SCAR6 is very, very rare. But this new repeat expansion ataxia, CANVAS, that you all know about, is actually quite common, especially if you look for it in the right group of people. So SCAR panel, we do hundreds of these, and Georgia will tell you more about this. And the hit rate is around 4%, but not more. Whereas in CANVAS, if you screen late onset ataxias, you have a hit rate that is above 10%. And if these patients have the full triad, of CANVAS, the hit rate is very high. So, of course, over the years, the unit has published several papers on repeat expansion ataxias, on Friedreich's, and now we're doing more work, of course, with NGS as well. I think this is important because this was a relatively undeveloped field in Greece when I was starting at the unit. Of course, joining EFACTS, being part of ERN R&D, and supporting the Greek ataxia patient groups. All these things are very important. So let me just conclude by saying that the neurogenetics unit at the Unitio Hospital has focused important clinical education and research work on Greek ataxia patients. And over the years, we have established a significant Greek hereditary ataxia registry that, of course, can get better and more complete. Our work is strengthened by the being part of EFAX and ERN R&D. Our data show that Friedreich's ataxia, of course, is the most common hereditary ataxia in Greece, with a widespread distribution. Other repeat expansion ataxias seem substantially less common, with a possible exception of canvas if you look for it in selected late onset cohorts. And of course, we are very happy that this networking for ataxia specialists is happening, and we want to work closer with all our colleagues around Greece. I think Greece is mature to move on to a next level of caring for these patients. And we want to continue working close with the Hellenic Ataxia Association. And again, thank you very, very much for the invitation.
Thank you, Professor Koutsis, because it was a very detailed and very presentation that shows exactly what's the situation here in the country. And of course, I could echo all your conclusions in terms of the need for patient registries as we are getting closer and closer to treatments. Our next speaker, and thank you for being here with us. Obviously, you are from the close by area, and the elections have not be a problem. And I present Argyris Dinopoulos, who is an associate professor in pediatric neurology at ATICO Hospital in Athens. He works with our patients in a very big hospital, and since Yorgos Tsivgoulis, who is supposed to present at the beginning, is not capable of joining, you will present the whole capabilities of ATICO then. Okay, the floor is yours.
Thank you very much for the invitation, and I'm glad I'm here. The elections brought me closer to you, so I'm gonna present you. Actually, I'm gonna move into the clinical grounds because I don't want to present our capabilities. It's pretty much the same as the previous one, and we'll collaborate all together. But I choose this title, Urgent Unmet Need for Friedreich's Ataxia Patient. And by urgent, I also give a time flavor, a time parameter, because the time concept is different. It's different for the patients, it's different for the caregivers, it's different for the scientist, it's different for the clinician, and it's different for the industry. As a clinician, I'm closer to the patient, so my thoughts reflect mainly patients' thoughts. I'm gonna present cases and just give our worries from cases. And I present Maria, who is a very beautiful girl, born on 2011. At the age of 6, she started having some running difficulties, some fatigue, clumsiness, nothing very important. But at the age of 7, she developed hypertrophic cardiomyopathy. We saw that girl at 7.5. She had the sensory ataxia and absent reflexes, so the diagnosis was pretty obvious. The genetic test was done, and she has Friedreich ataxia. Then we did have some evidence about medication because we have to provide something to our patient. The evidence was not that robust, but as Professor Zafiri has mentioned before, we need to do something. So we placed her on idebenone. So she started taking idebenone, and she was pretty stable on idebenone. And as you can see on the SARA test, and SARA test, ICARS, and the FARS test, she is even a little better. So we're pretty happy with that, but still we're worried. Now we have Maria, like just before the diagnosis, and trying to do the tandem walking. And 2.5 years after treatment, she's still doing pretty well. She's happy, but she's struggling a lot, and definitely she needs something better. Then I want to present some other cases, and that's Christian and Matteo, two brothers. And we start with Christian, that he has a peculiar diagnostic odyssey just before the diagnosis. Actually, he was diagnosed initially with cardiomyopathy. He even had a cardiac biopsy, and then developed some clumsiness, unsteady walking, falls, that brought him to a developmental pediatrician and then to a child neurology, and the diagnosis was made at that time. And his cardiomyopathy was quite substantial. He got treatment for that. And he was placed again on idebenone. And then we wanted to, and as you can see, the SARA test was not improved substantially, but actually you can see some decline on his motor abilities by that's going up, but that means the higher score is worse. So we see the SARA test and the ICAR test is getting worse. And here is the FARS test that still is getting worse. So idebenone is not working. And we had with this guy, because his brother was younger age, and we saw him just after the diagnosis, even without any symptoms. And we had the opportunity at that time to see if we could prevent this boy for cardiomyopathy, or for motor decline, since we have a patient that we can treat him early. We start idebenone right after the diagnosis without cardiomyopathy, but guess what? He was pretty stable, but at 1 year later, he developed cardiomyopathy, and his cardiomyopathy got even worse. So we failed to prevent the disease, even we treat him very early. So that's, to me, is a failure because nowadays, in all this neurodegenerative disease, we want to treat them early, before the neurodegeneration. And here, we had no luck. And we hear the SARA tests and the FARS test. And this is Matteo at diagnosis. We see him the tandem walking, that's a diagnosis. And then 2 years later, he's still ambulatory, he's walking, but his tandem walk is not, he's not able to do tandem walk. And that's actually, it's very sad for us to see that progression of the disease. And always we're looking for a light, always we're looking for something new, something to maybe to stabilize and even make this patient better. And we do have now some evidence about other treatments, the omaveloxolone. And still, I mean, the data is not that robust, but it's something that we want to try. But the age of, we can use this medication only because the study was done for patients between 16 and 40 years of age. So there is a limitation here. This is a limitation that it's very difficult for the patients, for the doctors, to wait until 16 years of age, to keep going with the neurodegeneration, to keep going with the cardiomyopathy, and wait until 16 years of age to try this medication. I hope to have more robust data before the age of 16, because I'm a pediatric neurologist, so we can have this tool, this weapon in our armatory. And I want to acknowledge our pediatric neurology department. We have a neurogenetic clinic. We follow 6 patients with Friedreich ataxia and a lot of other patients with neurogenetic disorders. And we collaborate with all other departments. We try to involve into trials and into the registry. Thank you very much.
Thank you, Professor Dinopoulos, because you showed us the perspective of the clinician on the early ages of our children. This is very important because it is we as parents, when we start this journey, we need to have to build on hope and to build on the idea that this disease or any ataxia disease at some point in time may be treatable. And the earliest this intervention comes into play, the better the effect and the better the results will be to the patient. So thank you for sharing this and for all the work that you are doing at Attiko Hospital. Yeah. Our last speaker for this Greek panel is our Professor Georgia Karadima, who is the co-director with Dr. Koutsis at the unit of neurogenetic testing and neurogenetic diseases in Aeginetio Hospital. Chryssa Konyari, who is actually with us today, she is there at the unit and performs all the cooperative tests with our patients. Thank you, Chryssa, for being here with us. And Professor Karadima, she will present us the capabilities that they have in terms of diagnosis, our patients, and not only for the patients, but also for the families. Thank you. Professor, the floor is yours.
Thanks a lot, the president of the Hellenic Hereditary Ataxia Association, for the kind introduction. Dear members of the present conference of the Euroataxia, good evening. I hope you have a very nice attendance of the conference today up to the Greek mountains. I hope that I would like to be with you, but because of the elections I can't. I hope another time I'll be there with you. So these are my disclosures. In the following 10 minutes, I am going to present you the neurogenetics laboratory of the National and Kapodistrian University of Athens that is situated in the Genetion Hospital. I'm going to give you some information about the genetic diagnosis that carried out in our laboratory since 1997, the quality of our tests. And at the end, I am going to talk to you about our activities for research, education, and clinical care. So, as my dear colleague, Professor Koutsis has already mentioned, the neurogenetics unit of a Genetion hospital is consisted of two parts, the neurogenetic outpatient clinic and the neurogenetic laboratory. The neurogenetic units achieve its goals through the close collaboration of these distinct but intertwined services which strive towards the establishment of a final diagnosis and the provision of comprehensive genetic counseling. The laboratory has clinical and scientific expertise in inherited neurological disorders and has systematically provided molecular diagnostic services at the national level since 1995, performing over 80,000 genetic tests for patients with suspected neurogenetic disorders. The lab is structured according to the international guidelines and is armed with the necessary technological infrastructure for the study of DNA, such as you can see in the present slide, automated nucleic acid extractor, thermal cyclers, imaging system for gel documentation, genetic analyzer, and most recently, very lately, a genetic analyzer for the operation of next generation sequencing. Our neurogenetics lab employs molecular biology techniques like Sanger sequencing, fragment analysis, repeat prime PCR, MLPA, whole exome sequencing. It follows external and internal quality controls periodically by the European Molecular Quality Network and quality control and the Cyprus Institute of Neurology and Genetics, respectively. The laboratory also follows a specific quality control manual, and we assume that it will be accredited successfully for the International Organization for Standardization, ISO 15189, by the GRID accreditation system ESID by the end of 2023. More specifically, we started the investigation of the molecular investigation of the hereditary ataxias in 1997 with the establishment of molecular protocols for the investigation of Friedreich ataxia. We continued in 2012 with the investigation of the major spinocerebellar ataxias like SCA1, 2, 3, 6, and 7. In 2015, we established the molecular protocols for the investigation of SCA17. In 2019 for SCA36, 2020 for FXTAS, and 2021 for Canvas. Last year, we started investigating all the other ataxias for point mutation using the new generation sequencing analysis. Until now, we have the largest clinically characterized cohorts of patients with hereditary ataxias at the national level. As for the genetic test, more specifically, over 1,400 DNA tests have been operated for hereditary ataxias in our lab since 1997. As you can see, we have done 682 tests for Friedreich ataxia, 456 for SCA panels comprised 1, 2, 3, 6, and 7 spinocerebellar ataxias, 92 for SCA 36, 93 for FXTAS, 99 for Kanban, 16 for SCA 17. So it's worth to mention that we are the only lab which operate in the public sector, which operates genetic testing for hereditary ataxias. In our lab, there is a biostorage of DNA samples from more than 1,000 patients all over Greece. So about our actions, as it has been already mentioned by my colleague, my dear colleague, Professor Koutsis, the past year, some critical papers about hereditary ataxias have been published in international journals by the scientific staff. Our projects in what is known as applied research, understanding the ataxias and assisting in their prevention. Our research activities mainly focus on the University of Athens. We are a center of expertise in neurological rare diseases for Greece and for the European Union. We are also members of the European Friedreich's Ataxia Consortium for Translation Studies, EFACTS. Our educational activities include undergraduate and postgraduate teaching, MSc dissertation, presentation, and talk for scientific conferences and patients associations. As you can see, we are a unique and relatively small lab, but as you know, no challenge is too big if you have the right team. All the members of our unit work hard and do their best for the study of patients with hereditary ataxias. We believe that we have much more to offer in achieving enhancement of scientific knowledge, the formulation of guidelines, and the best service for patients. We feel great joy that finally the approval of the first drug for the most common ataxia is a fact. We are going to stand by the Hellenic Friedreich's Ataxia Association side every time it is needed. Thank you all for your attention.
Thank you, Professor. Thank you all. Thank you for the panel. Professor Kimiskidis, Professor Koutsis, Professor Zafiriou, Professor Dinopoulos, and Professor Karadima. Thank you because you showed exactly what we can offer to our patients and as an holistic basis approach. And this is very important for the families and the patients. I think that we have exceeded our time and we will move on to the next session very quickly. Thank you.